We appreciate that. Thank you. Thank you very much.
Do you want to do the next one?
Next speaker here is just please announce it.
Okay. Next up is a presentation by Dr. Chang Liu. Is he here? Do we,
Chang Liu here.
is Dr. Chang Liu here? No. Remotely?
And is not on remote
He's
either.
not on remote. Oh,
Why don't you, Henry, go ahead, proceed with your.
will you introduce Henry? Yes, in that case, we'll move on to the last presenter in this session, Dr. Henry Weatherburn. Dr. Weatherburn is going to talk about a comparison of the characteristics of megavoltage, electron beams, and superficial X-ray beams used in keloid treatment.
Hello? It's working. Well, thank you. I was just reminding Dr. Glazer Passa, we did a presentation on treating patient recurrences, and he individually contacted a vast number of patients, went through all the records, and he contacted them. So our records were actually sound when we were looking at recurrence rates. Now, I'm now going to talk about a comparison of the characteristics of megavoltage electron beams and superficial X-ray beams used in keloid treatments. Now, at the 5th International Keloid Symposium, I presented a cost-effectiveness comparison of these two types of equipment. Both are employed for the treatment of keloids. And the comparison I made then identified KV X-ray units as being more cost-effective and simpler to quickly set up for patient treatment. Cancer treatment capacity issues, limiting linear accelerator access may also present as an issue in some centers. However, subsequent post-presentation discussion identified the need for an explicit physical comparison of the characteristics of these two treatment modalities to provide a more comprehensive perspective of their relative utility. So this is why I'm speaking about this now, to answer that question. Just briefly, sorry, it's not changing the screen. It's different there, yeah. Sorry. Yes, that's it. It's the next slide. I need now.
Doesn't map the bands.
It's not working. Something's gone. You're okay now. different. Same. It's the same. It's different. This is not something the progressive thing.
It's from the USB.
It's okay.
I could give you the USB if it doesn't. You can close on other. I can present a bunch of others maybe. Okay.
Yeah.
Yeah, it's showing, right? Yes, it's showing.
It's working. Okay, sorry about that, but technical issue. So these are the sets of data which I'm going to compare. The X-ray set, 60, 100, or 150 kV, and the electrons, 6 MeV with 5 millimeters bolus, 9 and 12 MeV with 10 millimeters bolus. And the important caveat, these are actually reconstructed data. Now, different manufacturers have got slightly different information, but the data is reconstructed from British Journal of Radiology information or using some manufacturer's data too. Now, the present study therefore compares those MEV electron beam and superficial X-ray beam characteristics most relevant to clinical decision making in post-excisional keloid radiotherapy, namely the beam energy, depth dose, field flatness, uniformity, penumbra, sensitivity to curvature, standoff, surface coverage, and management of long treatment fields. So I'm going to briefly discuss each of these, then come to some conclusions about them at the end. Now, these are details of the superficial units, the setup used, and the key context is that I reconstructed X-ray style beam qualities, and I said BGR, penetration, behavior, and likewise for the electrons, reconstructed standard clinical electron percentage depth dose behavior, and shifted it to a post-bolus skin distance to see how the penetration of the radiation goes through tissue. Here are the three superficial X-ray beam qualities used. 60 kV, which is very superficial, and it rapidly falls off within the first few millimeters. 100 kV, that's intermediate superficial beam, and it gives better coverage at 5 millimeter depth. 150 kV, and it's a shallow orthovoltage class beam. Its strongest coverage is 5 to 10 millimeters at depth, but it gives more dose at depth. Now here's a graph showing these depth doses, and it's for 25 centimeters focused surface distance. Now some superficial units have different distances from this. So as I say, this is representative data, and it's showing how the depth in water and how the beam falls off in dose, going through, and this is up to 3 centimeters, 30 millimeters depth. And that's a 60 kV beam, the orange one 100, and the green one 150 kV. And just the metric at the side where I've said D90, that's a 90% dose, is 1.5 millimeters deep for 60 kV, 4 millimeters deep for 100, and 10 millimeters deep for 150. And there are others. The D80 is 80% depth and so on. And as you can see, the 60 kV is very superficial. The 100 kV is a compromise beam for a 5 millimeter target. You can see that the depth dose is between 80 and 90% at 5 millimeters depth. And 150 kV extends much deeper, therefore exposes more tissue beneath the scar bed. And this is using the same reconstructed data, but tabulating it differently, because what we're really interested in is the dose at the different depths, 0.1 millimeter, 5 millimeter, and 10 millimeter depth. And you can see all of them are approaching 100% at the surface, but at 5 millimeter depth, the 60 kV has fallen already to 70.6%. So unless something very superficial is being treated, it's fallen off greatly. The 100 kV, 86.7%, so it doesn't quite make 90, but it's pushing up there at 5 millimeters depth. And the 150 kV is 96.5% at 5 millimeters and 90% at 10. So they can give good coverage, and the clinical perspective is all three cover an epidermal level target. At 5 millimeters, the 100 and 150 kV look much stronger, and at 10 millimeters, only the 150 kV clearly provides high coverage. So what depth is relevant for keloid excision? And got the new epidermal basal layer, not 0.05 to 0.15 millimeters. It's still very superficial after healing. The typical post-operative biological scar depth, 3 to 5 millimeters deep, useful working depth for recurrence prevention, and deeper planning when the scar is thicker, broader, or anatomically deeper, up to 10 millimeters. So the clinically relevant comparison is not 0.1 millimeter versus 5 versus 10, because all are true in different senses. Rather, the basal layer recurrence prevention, and occasionally we need to plan towards 10 millimeters. And looking at this is why the 100 kV often looks like a compromise X-ray beam for post-operative keloids. Now, if we look at the reconstructed bolus electron depth dose curves, these three graphs show the first one is 6 MeV, 9, and then 12 MeV electron beams. And onto those, we would put the vertical lines near the start at 5 millimeters depth. We put 5 millimeters of bolus to bring up the surface dose, because the surface dose may be less than 80% if it were applied directly to skin. So this is why we would apply maybe a wax layer, 5 millimeters thick, and that will bring the dose up for the 6 MeV beam to around 90%. And the depth dose then extends beyond that. We use a thicker bolus for 9 or 12 MeV, normally 10 millimeters thick. And that, again, is to raise the dose from a surface dose of less than 80% to over 90%. So the doses then at skin entry, that's under the 5 millimeters or 10, are 6 MeV's been raised to 91%, and 10 millimeter, the 9 MeV to 95%, the 12 MeV 96%. They still haven't reached 100, which is what the superficial beam will be at entry. So those are the electrons at clinically important target depths. You can see 6 MeV at one surface 91%, 1 millimeter 93% roughly, 5 millimeters 98, 10 millimeters 90, because it's beginning to drop then. And likewise, we can look at the 9 MeV beam at the 95%, 98. 10 millimeters deep, it's 100%. So the beam's overshooting that depth. So all three bolus electron setups currently cover 1 and 5 millimeters. The 6 MeV and 5 millimeter bolus already reaches 90% at 110 millimeters deep. And the 9 and 12 MeV are deeper than most post-operative keloid beds require. So the message practically is, amongst electrons, choose the lowest energy that still covers the real target depth. Now this is, I think, the most important of the graph. This is a side-by-side comparison at shallow, clinically important depths. And basically on the left-hand side, the three bars on the left-hand side are the X-ray beams, and the three on the right-hand side are the electron beams. So all of the X-ray beams are 100% at the surface. One can see them beginning to fall off at 1 millimeter deep, even with the 60 kV, and then continuing along at 5 millimeters deep, we can see that the 60 kV has fallen down to 70%. The 100 kV is said about 86.7%, and the 100 kV, the 160 kV is still quite close to 100%. When one drops to 10 millimeters deep, one can see the significant differences occurring. Looking at the electron beam, you can see all of those are less than 100% under the bolus, although they're over 90. They gradually climb up with depth, and then they begin to drop. The 6 MeV has begun to drop at 10 millimeters deep down to about 90%, whereas the other two beams, the 9 and the 12 MeV under the bolus, they're still around 100% level. And this is really the key graph as to what the side-by-side comparison. I just quickly looked at the iridium wire, which someone mentioned before. And if we have 100% at half a centimeter deep, if we take that as a reference point, then another half centimeter deep, the dose there will have dropped from 100% at half centimeter depth to just over 40% at the 1 centimeter depth. And if one goes out to about 5 centimeters deep, it will have fallen to a few percent, maybe 5% or so. Now, this is actually a comparison of the depth doses. So we've got the bolus electron fields and the X-ray fields, and you can see there is quite a quick drop-off with the X-ray fields, except when one goes to the 150 kV, it's more penetrating. Now, if we're interested in small depths and a reasonably quick fall off, then 100 kV is actually very good. 6 MeV would give slightly more dose beyond the depth that we're interested in, but it falls off a little bit more quickly down towards what we said, the Bremsstrahlung background, which is basically, there's an X-ray background, the electrons will produce X-rays, and there will be a few percent of a background dose which travels some distance through the body. So we can't just say the X-ray beam beyond the target, the dose continues to fall gradually with no sharp range cut off. The 150 kV persists deepest. The electrons, the dose falls steeply near the practical range and then continues to this low Bremsstrahlung tail, which I mentioned. And that's why electrons give shallow dose coverage with less dose below the target than a 150 kV beam. And while the Bremsstrahlung tail is real, it's lower much lower than the main electron plateau. So there's a decision table by target depth. At the basal area, any X-ray beam, any bolus electron beam, all provide high dose very superficially. A typical post-operative bed, 3 to 5 millimeters, 100 kV or the 6 MeV plus bolus, with good coverage, with better selectivity than deeper beams. If the bed's approaching 5 to 10 millimeters, 150 kV or 9 MeV plus 10 millimeters bolus, it's more defensible when the true depth approaches 10 millimeters. And if you need more depth coverage, one can use 150 kV or the 12 MeV. It's the highest penetration set. But for many post-operative keloids, the central choice is not X-rays versus electrons in the abstract. It's whether the real biological target is closer to 5 millimeters or closer to 10. And then you can select the energy. So depth dose is one characteristic. The other thing, another key characteristic, is the field flatness. That's a uniformity across the field. Superficial X-ray fields typically have a small penumbra, which can suffer, but can suffer Heel effect asymmetry, especially at lower kV and larger cone size. So the small penumbra is the blurring area around the edge, and it's very small in the X-ray beams. The electron beams are centrally flatter at the maximum depth, but lose usable width in the penumbra and retract in the corners. So the flat field is effectively more rounded than perfectly square. And for very long scars, applicator availability and the Heel effect, which is when the X-rays are produced in an X-ray tube, they make superficial X-rays impractical, pushing treatment towards a large electron field. So the rule of thumb for KV X-rays, nearly the full cone will be above 85%, especially 100 to 150 kV. But for electron fields, the 85% region is usually inset by a few millimeters at each side and more in the corners. I've given some examples here of the different KVs and electron field sizes, but it tallies in with what I said earlier. For example, 100 kV, 5 centimeter cone would give good uniform coverage from 4.8 to 5 centimeter diameter, whereas a 6 MeV circular cutout would only be about 4.5 centimeters diameter. So you're losing some of the field. Now, what's the effect of this? It's a planning margin around an X-size keloid. For the superficial X-ray unit, practical planning margin is pragmatically 0.1 to 1 centimeters. And there's different people cite 0.5 centimeter, and the majority, though, tend to cite 1 centimeter. However, for an electron beam, the practical margin around the scar or the suture line should be 1 to 1.5 centimeters, with up to 2 centimeters in broader, less conformal cases. So the electron series and reviews, they often specify 1 to 1.5 centimeters or even 1 to 2 because of the laterally constrained dose distribution. So the short rule is use about 1 centimeter for X-ray fields and about 1 to 1.5 for electron fields, expanding up to 2 for broader or less conformal setups. So the result is you need to treat a bigger field if you're using electrons. Another issue is curvature or standoff. And this is if one's treating, say, somewhere around a neck or so. Because of its short 25 centimeter distance, the dose falls off quite rapidly by this inverse square law for the X-ray field, and it would, if it were a 1 centimeter standoff, it would have fallen by 7.5%. The electron field, a similar size field, it would typically only have fallen off by barely 3%. However, there is a problem for electrons. The maximum dose on a curved surface will shift away from the surface, so it's actually slightly more complicated. So it is advantageous to be using the electrons, but it's not as advantageous as it would appear to be there, and because of the movement and the maximum depth of the beam. The next question is, if we have a very long field to treat, one thing we can do with the superficial is just match the field edges. Alternatively, we can get electron applicators, which may be up to 25 centimeters across. So if we had a 20 centimeter scar, the superficial X-ray cones might only be up to, say, 10 centimeters in diameter. So they're unavailable, or else they may not be too uniform. And so it becomes problematic with a long field. And a 20 by 20 centimeter 6 MeV electron field, well, it's not perfectly square. It avoids the dosimetric vulnerability of a field junction, because there's always a difficulty if one's trying to match two fields together. So the most important question here becomes whether one field can cover the entire scar with acceptable margin and curvature management. So what are the practical recommendations? So if it's a small, shallow post-operative bed, one could choose either 100 kV or a 6 MeV beam with 5 millimeter bolus. If it's a deeper bed, one could choose 150 kV or 9 MeV and 10 centimeter bolus. We need to minimize the dose under the target, so it's beyond the 10 millimeters or so that we're looking at. So we use the lowest adequate energy, if possible 100 kV rather than 150. If we have a very long scar requiring a continuous field, preferably one would use a large electron field over matched junction X-ray fields when feasible. And if there's an irregular curved site, X-rays tolerate the geometry less well, but electrons need careful bolus fit and setup reproducibility. So in many real keloid cases, the choice is between 100 kV versus 6 MeV plus bolus for a 5 millimeter depth target, and 150 kV versus 9 millimeter plus bolus for a 10 millimeter target depth. So the key takeaways: superficial and bolus electron beams can both cover post-operative keloid beds, but they're fundamentally different in dose below the target. 100 kV behaves like a pragmatic compromise for targets up to about 5 millimeter deep. 150 kV becomes useful when the real target approaches 10 millimeters, but it pays a price. It's got a deep dose penalty. 6 MeV plus 5 millimeters bolus is often the most selective electron choice for typical keloid beds. 9 MeV plus 10 millimeter bolus becomes defensible near 10 if the target's at 10 millimeters deep. However, the X-rays have a smaller per number. X-ray electrons offer better distal sparing but need more margin. So you're treating a bigger area. More care in curved surfaces and attention to rounded corners and usable width are an issue with electrons. Finally, for long scars, one electron field is usually more robust than matching two fields and that would be of X-rays and accepting a junction. And with that, I'll show these are the references which I have, and I'll say thank you and happy to answer any questions.
Dr. Weatherburn, thank you, Henry. That was a tour de force. I can understand that interests radiation oncologists. Now, one of the reasons we did this presentation was that the actual man that prompted all this isn't here, and that's Lamont Jones, because he needed to understand the difference between electrons, and some of our Chinese colleagues too, between electrons and superficial, because as our colleague from Japan said, the radiotherapy was given at another center. And as a surgeon, you don't tend to see all that. And I think those are important considerations. So you may have found it difficult to follow, and for that I apologize, but it's like a surgeon speaking about their sutures, or the dermatologist about their creams and so on. They go into detail. We have to do that with radiation. The only people that don't really have that are the chemotherapists. And Dr. Turgan's not here either.
Oh, he is.
Is he?
He is in.
Good. Good, Dr. Turgan. Because having done medical oncology myself, I know the structural elements are not there because it came since I became an oncologist. It's all relatively new. And so I liked it that he said he tries it. And I liked it that he said he uses different chemotherapy agents for multiple keloids. But what I didn't really understand is when he recurred, he said he used the same agent again. One day he must explain that to me with the chemotherapy. If it recurs on a particular drug, why do you give it again?
Yeah, sorry, could we just stick to the radiotherapy at the
We'll
moment?
just stick to
Yes.
This doesn't work. You switch the topic. You switch the topic from radiation to chemotherapy. I'm more than happy to take on that challenge.
Yeah, no, we deal with the radiotherapy, of
I'll
course.
try to be very brief and let you have your conversation about radiation therapy, because this is the radiation therapy
Yep,
session.
yeah.
So very briefly, depends on when the recurrence happens. Same thing applies to treating cancer patients. If you have a patient who is receiving chemotherapy, drug X, and 2 weeks later, the disease is worse, a month later, the disease is worse, of course, I'm not using the same drug. Nobody would use the same drug. However, if you used combination AYZ, and the patient achieved complete remission and came back 6 months later with minor recurrence, of course, I would use the same treatment.
Thank you for that. Thank you. Henry, any questions, please?
Yes.
Is it too clear? So
This is just a very
it's too-
quick
too-
technical
Which
question.
one?
Oh, all right, I'll go. So is there any, from a practical point of view, is there any difference between the amount of time it takes you to deliver, say, 10 gray at 60 kV versus 10 gray at 6 MeV? Are they about the same in
right.
terms of amount of time taken?
The dose rates would be similar, but the time taken would normally be shorter with the superficial unit because it's much easier to set up. And the oncologist would come and actually look and say, we'll do it there. There would be an area marked. The oncologist would come and confirm that the setup was correct. It takes longer, as you may have seen from the Dr. Sau's slides with the electron linac. It takes a bit longer to set. It's a more complicated system to set up. Yeah.
Thanks.
Thanks very much for your presentation. I think with your presentation, we know much about the radiation in practice. My question is, I know in your presentation you said the electron will disappear sharply with the dips. In my practice, one of my radiotherapy department physician told me if there also some radiation in the deep layer of the body, and months before, I have a patient with keloid in the pubis, and after surgery, I asked the patient to get electron therapy, and the physician refused to do this because he thinks there also some influence for the ovary of the patient. I confused Can you explain this for me? Thank you very much.
Yeah. Well, not quite clear what I'm defending.
Not quite clear.
I think, are you talking about the depth dose or the about the dose with depth, or
Yes, those of the tips.
yeah?
There are also some dose in the tips of the body.
Yeah, no, if you look at the graph, which you said 100 kV, it does penetrate further down when the dose is much lower, of course. It's come down maybe to 20%. That penetrates a little more. But the electron dose at the start is penetrating beyond your target. So those are the two differences, but they're not hugely different. The other thing, though, is the electrons are a bigger field. And people talked about cancer risk area. If you've got a small area and you make it maybe a half or 1 centimeter bigger all around, you've doubled the cancer risk because you've made the area much bigger. So there are, what I was trying to say, in circumstances, the electrons are better if you've got a long field and you don't want to match. So in those circumstances, it would be better using electrons. It may be better if there's a big curvature as well. But in other cases, the differences in depth dose are not all that huge for 100 kV at 5 millimeters deep, and that would be maybe most of the work. So I would say the superficial machine, and this is why it came up originally, is maybe 10 times less expensive than the Electron Linac, and also uses a lot less staff to run it. It's doing it much more cheaply, and you get roughly equally good results. But there's one that's yeah.
I want to know if there any difference
We also have,
for the
we also import ortho too.
organs in the body use electron beams for therapy.
Are you talking in the body with the depth dose? I said, in my opinion, the differences aren't very large for 100 kV beam and a 6 MeV electron beam plus bolus. There are differences, and I think I should have highlighted that specific example, but I don't think the differences are very, very great there. Yeah.
You can bring up that percentage
Oh,
depth dose if you want.
Something else up.
They've put something else up.
Oh, okay.
Is that okay?
Yeah. Sorry, they've gone to the next presentation. I can't show you it. Yeah.
Long day. Yeah. Thank you very much. I just want to briefly share this from Professor Akeda's slide set, John, that you were talking about. This Kaplan-Meier curve of recurrence after surgery is very important. As you can see, there's 100% no recurrence immediately after surgery, but then gradually the recurrences occur, mostly in the first 12 months, then 24 months, and she has some recurrence at 36 months, and then they haven't identified recurrence past 36 months. So perhaps in her data set, their patient, their center treated that way, those who did not recur in the first 3 years, they are cured.
It says 77.
I wanted to emphasize this slide set of her presentation.
Okay, thank you. Thank you, everyone.
Thank you very much. So we'll reconvene in 15 minutes.
I didn't understand exactly. No, I mean,
I think this was the thing that came up on what's that one selling superficial machines?
yeah.
And she said, oh, they're saying that there's huge penetration in the X-rays and the electrons cut off. See, they've told the surgeons the electrons go almost like that.
No.
Whereas the X-rays go like this.
Right, but
And I couldn't get my,
you have a pen, like, I think. Yeah,
I think-
sorry, we didn't quite understand what you were asking. So,
The electron
yeah,
will be disappear sharply.
no,
Yeah,
well, it doesn't, if you have to,
I wish I could get.
I don't know, you have a pen or something, like,
No,
that
if I
just,
could get my slide up.
yeah, we can get your slide back. Okay, so you have to look at the percentage depth dose curve, and you had some examples.
Yeah, there was one where I did a
Yeah.
comparison.
Where's your, okay, so where's your, where's your, oh, jeez.